Welcome to the presentation of Illness and Infection in Older Adults, a module contained in the programming of Enhanced Orientation for Nurses New to Long-Term Care. This was a project that was supported and funded by Manitoba Health and Healthy Living. Illness can present differently in older adults. As well, the results of illness in older adults can be more debilitating. The good news is that with timely detection and intervention, these adverse consequences can be prevented or minimized. Concurrently, our pride and satisfaction with our work will no doubt be enhanced. Please ensure that you have access to the workshop module that goes along with this presentation in order for you to answer questions, make notes, and share the detailed information upon completion of this module with your clinical team manager. Thank you and enjoy the rest of the session. Enhanced. The learning objectives of this module are as follows. Explain what is unique or atypical about the presentation of illness in older adults. Describe why older adults may present atypically when ill. This section will include the ability to identify the frail older adult. Describe how older adults may present atypically when ill. Implicit in this is detailing the critical indicators or geriatric giants that affect our elderly population. And lastly, describe the presentation of some illnesses common to older adults. Explanation and details related to frailty, critical indicators, and geriatric giants will be provided in upcoming slides. If you think you know what you're looking for, think again. Amelia's quote from her 2006 article in the American Journal of Nursing effectively draws our attention to the uniqueness of the presentation of illness in older adults. To provide evidence-based best practice to older adults, we need specific assessment skills and an understanding of the normal aging process. This is so important in order to differentiate between the normal aging changes from the onset of illness or the worsening of a chronic illness. We must understand atypical presentation of illness. If the altered presentation of illness is not understood by healthcare professionals, missed diagnoses can occur, resulting in increased suffering, disability, morbidity or illness, and mortality or death. The complexities of multiple coexisting comorbidities. We must understand this because the existence of multiple conditions and multiple medications makes assessment for us much more challenging. Specialized skill and knowledge are needed so that early recognition and treatment can occur while recovery is still possible. We now proceed to some mention of population trends and the impact this has for older adults and healthcare. In this graph here, we see the percentage increase of people aged 65 years and over in the Canadian population from 1921 to 2005, as well as the projected increase in this segment of the population all the way up to 2056. It is steadily increasing. The percentage of people aged 65 years and over more than doubled between 1921 and 2005 and is projected to more than double again by 2056. Of note also is the fact that the 80 years of age and over group is the second fastest growing segment of our population. The 55 to 64 year age group is the fastest growing segment. Almost 1.2 million people were 80 years of age or older in 2006. This population trend underscores the importance of understanding the complexities and uniqueness of the healthcare needs of the oldest old of our society. What do we mean by atypical presentation of illness in older adults? Some older adults present with the classic signs and symptoms of illness. However, presentation of illness and infection in older adults is often atypical. That is, presenting symptoms are often very different from those of younger adults and children. The classic signs and symptoms may not appear, or may appear only in a very vague manner. This does not fit with our conventional understanding and knowledge or education of illness presentation. Of significance also is the fact that when disease does strike older adults, the effects can be much more debilitating than that in younger adults. Older adults with acute illness may present with an absence of the usual defining symptoms. An example of this is a painless or silent heart attack, myocardial infarction. An altered spectrum of symptoms. An example of this is apathetic hyperthyroidism. So when we think of hyperthyroidism, we think of someone revved up. However, apathetic hyperthyroidism is an altered spectrum of symptoms often seen in older adults. Lastly, a stereotyped presentation in another system or systems may present. An example of this would be with the geriatric giants, and that is yet to come. Now that we have addressed what is meant by atypical presentation of illness and infection in older adults, we will examine why this occurs. We begin this discussion with a brief explanation of the concept of frailty. The recognition of frailty is important because frail older adults are more likely to exhibit atypical presentations of illness. In this model, published by Rockwood and Associates in 1994, pictured in the lower right-hand corner of the screen, we see assets on the one side of the scale and deficits on the other. Assets include health, attitudes toward health and health practices, resources available to the older person, and caregiver support. Deficits include illness, disability, dependence on others, and burden on the caregiver. This model is dynamic and complex, involving an interplay of assets and deficits, and it incorporates a holistic concept of health that includes medical and psychosocial perspectives. This is the well elderly. Their assets well outweigh the deficits. Assets predominate. For the frail elderly, deficits predominate, and this may necessitate the need for personal care. Other indicators of frailty have been identified. These indicators include age over 85 years, considered the old, multiple comorbidities or chronic illnesses, multiple medications, cognitive impairment, functional impairment, reduced mobility, and poor nutrition. This list is not meant to be all-inclusive, but definitely helps highlight those frail elderly that we care for. We now move to a more in-depth discussion of the underlying reasons why illnesses present differently in older adults. Normal aging changes, that is, changes in overall body composition, are a hallmark of aging. Alterations in cell replication occur. For example, this so-called senescence of cell replication can reduce the immune system's capacity to respond to pathogens and impair wound healing. As well, organs age at varying rates in different people and at different rates within each person. For example, the heart may be strong while the brain exhibits aging changes. As well, older adults tend to have multiple chronic illnesses. Multiple diseases can interact with each other to produce more disability. For example, osteoarthritis could produce an odds ratio of disability, OR, of 4.4, and ischemic heart disease could produce an odds ratio of disability of 2.3. But when you combine those disabilities together, they could produce an odds ratio of disability well above both original rates added together. To add to the complexity of this disease, the treatment of a disease can have an adverse effect on other disorders, causing disease treatment interactions and polypharmacy issues. For example, the treatment of arthritis using drugs like NSAIDs or prednisone can also impair wound healing. Living long enough usually entails a medication regime. Older adults take more medications and are more at risk for adverse drug events and drug-drug interactions. Age changes the way the body handles drugs. With respect to absorption, in older persons, absorption is generally complete, just much slower. With respect to distribution, with aging there is a loss of lean body mass and a gain in adipose tissue. As well, there is less fluid available in the body. Protein malnutrition is common. With these changes, the distribution of water-soluble, fat-soluble, and protein-binding drugs may be altered, causing potentially harmful effects. Kidney and liver function as well as serum albumin may need to be closely monitored in order to avoid toxicity or undertreatment. The rule of thumb for drug administration in the elderly is to start low and go slow. Another reason why illness may be expressed atypically is that pain may be experienced and communicated differently with aging and cognitive impairment. Visceral pain thresholds are increased, thus classic signs and symptoms may not be present in illness such as cardiac disease, the silent MI. Recognition of atypical signs and symptoms can result in early detection and treatment. As well, older adults may have difficulty pinpointing pain location and evaluating pain severity. In people with dementia, give attention to nonverbal cues. Cognitive changes can also affect the presentation of illness in older adults. The presence of depressive illness reduces the desire for improvement. The presence of depression and/or dementia can affect the older adult's ability to recognize and articulate the presence of illness. Of note is the fact that the presence of depression and dementia can also impact the ability of healthcare providers to recognize and optimally manage illness in the older adult population. Some older people with mild dementia deny illness for fear of economic, social, or functional consequences. For example, they may be afraid of having to leave their home or go to hospital. And that's a very real fear. Factors other than clinical issues can affect illness presentation and recognition. Underreporting of illness can be a factor affecting illness presentation. Ageism can play a role in underreporting. Disability and morbidity are still viewed by many as just age-related changes. Example, what do you expect? He's old. That's just not the case. Lack of education can also play a role in underreporting. Although interest in and educational opportunities for advancing skill and knowledge related to the care of older adults has improved, we are still not adequately prepared to meet the healthcare needs of the older adults who comprise a significant proportion of our population. There are many ageist jokes that undermine the aging process. I'm not sure if this one is positive, but at least it does not depict the typical stereotype of the aging adult. In addition to understanding why illness frequently presents atypically in older adults, it is necessary to understand how illnesses can present in this group of people. The most susceptible and most likely areas to be affected by illness are the neurological system, specifically the brain, the genitourinary system, specifically the bladder, and the musculoskeletal system. This reinforces the need to investigate for an underlying cause for even small changes in any of those areas. The first sign of acute illness or an exacerbation of a chronic illness in older adults is often a subtle change in condition and/or function rather than specific complaints related to a specific organ system. Experienced nurses or healthcare assistants will notice that something is just not right. For example, Mr. Jones is suddenly unable to ambulate independently to the dining room. Or Mrs. Peters is taking no interest in her visitors when she previously looked forward to their visits. It's those small changes that say something else is going on. Functional and cognitive deficits usually affect the older person's ability to perform necessary ADLs or independent activities of daily living. A baseline assessment and serial assessment as the resident's condition changes facilitate accurate diagnosis and management. It is important to get a clear understanding of what has changed and how has it changed. Older adults often manifest with the onset of worsening of one or more of the geriatric giants when they become ill. The geriatric giants were articulated by Isaacs in 1981. Some of the literature refers to them as syndromes or indicators of illness. The geriatric giants, as articulated by Isaacs, are immobility. That's the inability or reduced ability to ambulate or move about in one's surroundings. Keep in mind, it's a change to immobility as well that you need to highlight. Instability. Instability refers to falling or being more prone to falls. Again, you're looking at a change from baseline. Incontinence. This can be new onset or the worsening of existing incontinence. It's telling you something else is going on. Intellectual impairment. This refers to the onset of a delirium or acute confusion. Delirium will be discussed further in an upcoming slide and also in another module. These all relate to the neurological system, the urinary system or the musculoskeletal system, and ultimately cause a change in function or cognition. Older adults often manifest with the onset or worsening of one or more of these geriatric giants, when other indicators of the onset of illness in older people can also include dizziness, eating and drinking difficulties, dehydration, weight loss, failure to thrive. Such indicators tend to be nonspecific and can lead to overuse of medications, leading to polypharmacy and/or more health-related problems related to interventions of the medical system, and that we call iatrogenesis. So with this slide, any of these things that are different or new for a resident indicate something else is changing. Could be an onset of a new illness or an infection. The geriatric giants and other nonspecific indicators are often the first major sign of a disease occurring in an organ system remote from the affected organ. For example, an 87-year-old woman with pneumonia may present solely with delirium and falls. Think about a time where you saw a change similar to this in a resident and the actual problem was an illness or infection starting, but that didn't present itself straight away. In a study carried out at the Victoria General Hospital in Halifax and published in the Archives of Internal Medicine in 1995, the authors found that atypical presentation of illness was more common in people who were frail prior to the current illness for which they were admitted. The results of the study showed that 25% of the well elderly presented atypically and 59% of the frail elderly presented atypically. So what does this tell you? Of those who presented atypically, the frail most often presented with delirium and the well most often presented with falls. The well elderly presented with falls and functional decline more than the frail elderly because they were functioning at a higher level in these domains prior to the onset of illness and hospitalization. For the next few slides, we'll focus in on infections. Infections in older adults are more frequent, more severe with higher mortality rates, and may present differently than in younger adults. Atypical symptoms can lead to delayed recognition and subsequently to increased morbidity and mortality. Changes in the immune system called immunosenescence are thought to account for these differences. Aging changes vary from one person to another. Some elderly remain physiologically young and when an infection develops, present with typical signs and symptoms. However, atypical presentation of infection is common for people who are 80 years of age and over, who are frail and suffering from multiple medical problems. Fever is absent in 20 to 30% of older adults with serious illness. Unfortunately, this often results in delays in diagnosis and poor outcomes. Temperature readings in the elderly are an imprecise measure of the presence of infection. Some older people have a lower metabolic rate and lower core temperatures. Therefore, older people with low temperatures may actually be experiencing a significant temperature hike. An accurate baseline temperature is so important to have. Due to the frequency of an altered febrile episode in the older elderly, a new definition of fever has been proposed by some experts. It has been suggested that fever be defined as persistent elevation of body temperature of at least 1.2 degrees Celsius over normal values, regardless of temperature measurement technique, or a persistent elevation of oral temperature of 37.2 degrees Celsius or greater, or a rectal temperature of 37.5 degrees Celsius or greater, on repeated measurements. The fever and chills that are commonly attributed to an infection are often replaced by delirium and decreased functional ability in older adults. It is important to note that delirium can present as a quiet confusion where the older individual appears weak and tired. Sadly, these infections may go undetected. With delayed detection, the consequences can be serious. The next few slides will explain how some common infections can present in an atypical manner. Urinary tract infections can present with symptoms such as incontinence, new or worsening, delirium, new or increased confusion, falls, fecal impaction. The usual symptoms seen in younger people, such as urgency and burning, may not be present. Infected pressure ulcers can present with delirium, fatigue, falls, and ultimately loss of consciousness. Infected pressure ulcers, or any infection of a wound type, are a leading cause of septicemia in the elderly. Pneumonia. The classic signs and symptoms of fever, chill, cough, expectoration, and shortness of breath are seen less frequently in the older population. Atypical presentation can include constitutional symptoms, symptoms that relate to the entire body as a whole rather than an individual organ, such as delirium, fatigue and weakness, lethargy and impaired functioning, and impaired mobility and falls. As well, an increased respiratory rate along with hypoxia may be observed. This phenomenon was noted many years ago by Sir William Osler, who stated that in old age pneumonia may be latent, coming on without chill, the cough and expectoration are slight, the physical signs ill-defined and changeable, and the constitutional symptoms out of all proportion. Influenza. Cough, fever, and chills may be present. However, delirium or an acute confusional state along with weakness and falls are frequently the presenting symptoms in elderly. The prevalence of heart failure increases with age. Although the elderly may present similarly to the young, it is common that typical symptoms such as exertional dyspnea may be absent in the elderly who are not very active. Atypical presentation of heart failure can include things such as delirium, falls, decreased appetite, weight gain of 2 to 3 pounds, and complaints of poor sleep or fatigue. Thyroid disease is prevalent and can present atypically in the elderly as well. Apathetic thyrotoxicosis is a term that's used when elderly patients do not present with the classic signs of hyperthyroidism. The elderly can present as depressed, fail, with anorexia, weight loss, unanimated affect. They may not even have an enlarged thyroid or even palpable thyroid gland. Many signs and symptoms of hypothyroidism are missed because they are attributed to aging problems. Signs and symptoms of hypothyroidism can include constipation, lethargy, cardiomegaly, mental deterioration, fatigue, and weakness, things that we see every day. Diabetes can also present atypically. Hyperglycemia. As the blood sugar rises, the classic symptoms of increased thirst, hunger, and urinary output may or may not be present. In the elderly, dehydration, delirium, and incontinence are more likely to occur. In the later stages, a wasting disorder with weight loss instead of weight gain may develop. If polyuria is present, it can be confused with other disorders such as incontinence or prostate difficulties. With hypoglycemia, delirium can be an early symptom. The SPICES tool is an overall assessment tool that is based on scientific evidence that normal aging is associated with irreversible physiologic changes that predispose the older adult to increased risk or hardship in maintaining health and wellness. This tool is comprised of commonly occurring syndromes that can manifest or worsen with the onset of illness. Other literature refers to these disorders as geriatric giants and indicators that we've previously talked about. SPICES is an acronym for the most common syndromes affecting older adults. S for sleep disorders, P for problems with eating and feeding, I incontinence, C confusion, E evidence of falls, and S skin breakdown. The use of SPICES can flag syndromes, those geriatric giants, for further assessment. It can assist with assessment by identifying what has changed. So anytime you're seeing a resident with changes in any of these areas, know that something else is likely going on and do an investigation. This helps facilitate and focus preventative and therapeutic interventions. The next two slides will give more information. An accurate assessment of confusion or delirium should at least include the answers to these three questions that are part of the confusion assessment method. Did the confusion happen rather quickly, since admission or the onset of illness? And are there times during the day when the person is more confused than at other times? Is the person easily distracted and inattentive to tasks or conversations? Does the person have an altered level of consciousness? Are they overly alert? Are they groggy or stuporous? The Confusion Assessment Method, or CAM, is a great guide and tool for assessing for delirium. Look in the case study in your workbook and answer these questions. What geriatric giants, as described by Isaacs, 1981, are evident in this case? How does completing the SPICES assessment assist you in clarifying and describing the changes in Ms. J's health status? What follow-up might you do? Any further questions, further assessments? Would you contact the physician? If so, why? What would you say? What would you do? We must provide best practice by recognizing and acting on atypical presentations of illness in older adults. By doing this, we can help to prevent missed opportunities for early treatment and the development of more negative health outcomes. We are striving to promote elder-friendly care across the continuum. Care of the older adult offers specific challenges due to atypical presentation. Changes in cognitive and functional status need to be investigated for underlying causes. Healthcare interventions need to reflect the needs of the older adult. The times are changing in terms of how we care for older adults, and we must be prepared. Thank you. Please hand in your workbook and discuss your answers, or if you have any difficulties, with your clinical team manager.